So today we'll briefly discuss about water-soluble vitamins. Okay. So vitamins are basically organic compounds which are required in very little amounts for some specific biologic function. It derives from the Greek word vitamin, which means vital for life. So they are essential for the normal functioning of the body. And the important thing is most of them cannot be synthesized in the body. So you need to take it from external sources. They're classified by their biological and chemical activity, not by their structure. So there's nothing B1, B2 are not related by structure at all. It's only based on their biological and chemical activity. So today's class is only on water soluble. I'll just give one brief overview about fat versus water soluble. So as the name suggests, this is hydrophobic and this is polar. And important thing for fat soluble, they are named so because they require fat for absorption. So I'll just show in the subsequent slide. This system is involved. So lymphatics are involved for absorption of all the fat soluble vitamins. For water soluble, that's not required. And fat soluble vitamins are stored in the liver and adipose tissue. Water soluble are generally not stored. So because they are hydrophobic, so while they are getting transported in blood, you need some proteins. So they are the lipoproteins. So lipoproteins is also essential to carry these things forward. But because they are water soluble, they really don't need all that. And through the biliary system, they get excreted through the feces, and this is a water soluble, hence it will come out through the urine. And important thing about cooking foodstuffs, when you should realize that most of the fat soluble vitamins are stable, whereas water soluble vitamins are unstable, so they easily get lyse. So if you overcook, you will lose all your water soluble vitamins. So that's an important clinical point we should remember. Many times patients may say that they are really taking a lot of water soluble vitamins, but the problem is because they are unstable to heat and light, they are not eventually getting absorbed. Fat soluble, as they get stored, they are prone for toxicity. Water soluble, they really do not get stored. You eat a lot, you will excrete a lot. You're not really going to store them, so toxicity is exceedingly rare. The classical fat soluble are ADEK and B and C complexes are the water soluble. Today I'll touch upon B. C and folate B12, there is a separate class I think for that. Okay, so how do these vitamins get absorbed? So oral cavity, so you have all these enzymes. So once you chew small particles, they'll release the vitamins from the food, whatever you've taken. So when they go to the stomach, the digestion starts, so all your vitamins are released. So some from the oral cavity, and as you go down the stomach, you get some of them coming out. So the gallbladder releases bile, which will emulsify fat and help absorbing fat-soluble vitamins. So you really need the support of biliary system here for absorbing the fat-soluble vitamins. The pancreas will secrete enzymes that will aid in release of further vitamins. So at each step, some vitamin keeps on getting released, and then you need the biliary system to absorb the fat-soluble vitamins. Where will they get absorbed? Obviously in the small and large intestine. So this is where they differ. Okay, so in the small intestine absorption, fat-soluble vitamins, they form micelles, must have read in biochemistry, right? So then they form with bile acids and then they get absorbed. Okay, so this is what happens for fat-soluble vitamins. So they incorporate in the cells and then absorbed by diffusion. Once they're inside the cells, they are packed in chylomicrons, which then enter the lymph. So it is going to enter the lymph. So from the circulation, from the intestine, the fat-soluble vitamins will form micelle complex, enter the gut mucosa. From there, they're going to enter the lymph. Through the lymphatic circulation, they'll enter the blood circulation finally. Okay, as the lymphatic system goes, drains here, and then it will reach the circulation. So that's how fat-soluble vitamins enter. So these areas are very important. So you need this structure, you need proper synthesis of biliary system, bile acids are required to adequate micelle formation, and then they get absorbed. Chylomicron formation is important, and then they absorb to the lymph. Whereas water-soluble vitamins are very straightforward. They easily just get absorbed and enter the blood in the other side. Okay, so many depend on energy requiring transport, must bind specific molecules. So here is where at varying levels different vitamins get absorbed. So you need some cofactors, you need some particular enzymes which will differ for each of these vitamins, and based on that they get absorbed. So in the large intestine, bacteria also synthesize small amounts of certain vitamins, and some of which can be reabsorbed. Okay, so this is the basic difference in the absorptive mechanisms of fat soluble and water soluble vitamins. Okay, basics clear. So what is fat soluble? What is water soluble? What are the basic differences in these vitamins? How do they get absorbed? So this much is essential to know. Okay, now we'll go into the water soluble vitamins, which is for discussion today. So thiamine, so B1. Can you name what are the various B vitamins? B1 is thiamine, B2, okay, B3. Okay, is there any B4? Okay, B5. Anybody last bench? B5. What is B5? Yeah, white shirt. Last, yeah. Okay, okay. B6, next fellow. Yeah. Okay, B7. Folate. Okay, so we'll discuss these things. So I'll discuss in this structure, we'll discuss about how important this vitamin is, then I'll talk to you about how they get, what are the various sources, how do they get absorbed, what are the problems in the, if they are deficient, and how do you manage, okay? So we'll look at each of these vitamins in this format. So thiamine. So thiamine pyrophosphate is a coenzyme in carbohydrate metabolism. This we must have read in biochemistry. So for entire carbohydrate metabolism, thiamine is very important. So without thiamine, so this immediate energy release is going to be defective. So as we have read, it is a coenzyme in transketolation and decarboxylation of alpha-keto acids. So again, energy releasing. So it helps form acetyl-CoA from pyruvate, and this will then go on to the subsequent Krebs cycle and then generate phosphate. They also participate in the HMP shunt, so they generate an ADP, again another source of energy. And they're important for nerves because they help in acetylcholine synthesis. Okay. I only put on the key functions of all these vitamins so that at least before the exam you will be able to revise all of this. You should be able to answer at least 2 or 3 of each of these vitamins. Okay. Most of this it's already known. You must have read in your first year MBBS. Okay. So how does it get absorbed? So liver, meat, milk are all good sources. Okay. So for each of them, I've tried to put some pictures so that you can see them and realize and remember some of them. So whole grain and enriched cereals will have good amount of thiamine. So milk and eggs also have good amount of thiamine. So generally, if as long as your intake is moderate, you will not have thiamine deficiency. So there are specific situations like alcoholic, very poor oral intake, elderly, that's when you get B1 deficiency. Not very common in children because milk has nearly sufficient amount of thiamine, and most of the children are going to be on milk-based diet, so we generally don't see so much of thiamine deficiency in pediatrics. The important point, as we discussed, all water soluble get easily destroyed. So they're easily destroyed by heating, thawing, and polishing cereals. So this is one important thing. So most of the rice we eat is polished rice here, for many of them. So that's why inherently the food intake, if in an adult, and milk and egg intake is very little, and you only predominantly take polished cereals with a lot of alcohol consumption, that's when deficiency happens. Otherwise, not much. Okay. Absorption is very good in the GIT, and liver and GI disease, as we saw, will decrease the absorption. The recommended dietary allowance for thiamine is 1 to 1.2 milligrams per day, roughly around 1 milligram a day. So what are the manifestations of thiamine deficiency? So early and late. Initial manifestations are very non-specific, but then CNS symptoms and CVS symptoms are the ones which predominate. So you start developing signs of peripheral neuropathy, and then you start developing congestive cardiac failure. And if it progresses, you end up getting increased intracranial tension, coma, which we rarely see. So the classical deficiency of thiamine is very uncommon in pediatrics. So the classical subtypes are wet and dry. So in wet, I'm trying to say there's a lot of fluid accumulation. So basically it is a CCF, congestive cardiac failure, and fluid accumulation. That's why it's called wet beriberi. So it's CCF leading to edema. That is a typical manifestation of wet beriberi. Whereas if it is dry beriberi, it's going to be more of, there's no edema here, there's no CCF, there's more of neurological manifestations. And that's why it's called dry beriberi. Okay? So, how do you diagnose? So, most of these vitamin deficiencies, there is no real specific test which we do to pick up. Very few hardly have any test. So, it's only clinical suspicion and good dietary history in a specifically risk population, at risk population, where you try and look for these things. The symptoms are really non-specific. So RBC transketolase enzyme levels are low. We hardly do it in clinical practice, but to know about this, you can say this is kind of fairly specific. And you have high blood and urinary glycolate levels. So the simple thing is, if there's at-risk population, what we generally do is we end up giving thiamine to all these patients, especially if they're alcoholic, they're poor oral intake. We end up giving large amounts of, we generally give thiamine along with the fluids which we give. So in children, most of the time, because it's through the milk, and if children get deficient, then probably the mother is also deficient, so treat the mother as well. That's an important point here. Okay, most of them are breastfeeding or on mother milk-based products, so you need to treat the mother as well. So dose is 10 milligrams per children. 50 to 100 milligrams of thiamine is given in adults. So given part of IV fluids and run it through the first time when they get admitted. Okay, so this will just summarize what is this Wernicke's encephalopathy. So this is a Kane criteria which is proposed, where 2 out of these 4 has to be seen. Change in mental status, oculomotor dysfunctions, cerebellar dyslexia, and you find this nutrient deficiency. But this classical triad is not commonly fulfilled. We will suspect in at-risk population, so especially in those with chronic alcoholism. Okay, so these are the risk factors. And intravenous thiamine, 50 to 100 milligram, is the treatment. So as soon as you consider, you think you suspect, you give. So as a routine, what we do, when you go to medicine wards, you'll realize that any alcoholic male comes with altered sensorium. For everybody, will get 1 dose of thiamine. So that's how we end up treating them. So administration of glucose without thiamine will worsen. So as soon as you get admitted, you put a cannula, run fluids, you start thiamine simultaneously. Okay, and there's going to be prompt improvement in all these neurological symptoms if there was thiamine deficiency. Okay, so this is in a nutshell about B1. In riboflavin, it is also again involved in energy metabolism. It's part of 2 coenzymes, FMN and FAD. They participate in citric acid cycle, electron transport. So they remove ammonia during deamination, and they are associated with antioxidant. These are the important functions of riboflavin. I've taken all this from your first year textbooks only, for physiological functions. I've jotted it down so that it will be easy for you to write if a question is asked on this. Sources. So most of the time you can remember that meat, you write eggs, milk, you're reasonably safe for most of the vitamins. Okay. Milk and yogurt supply about 15%. So most of the plant and animal based foods will have B1, B2 to B1 in sufficient quantities. So the RDA is again 1 to 1.5 milligrams per day. Okay, so deficiency features. Riboflavin is more of oral manifestations. There's going to be glossitis, angular cheilitis, itching and burning eyes. Okay, so many manifestations in the eyes are shown: keratitis, conjunctivitis, photophobia, lacrimation. Okay, so try to remember all these clinical features. Each of these vitamins will have something unique. Whatever is unique, I've tried to put a photo so that when you rush through the slides, you'll be able to remember. So some eye manifestations and some glossitis, cheilitis is of vitamin B2 deficiency. Again, the diagnosis is clinical. So the treatment is 3 to 10 milligrams of riboflavin daily. B3, niacin. So niacin forms 2 cofactors, NAD, NADP. They have a key role in oxidation reduction. So they convert pyruvate to lactate, important for electron transfer. Coenzyme component participates in over 200 metabolic reactions, so hence its importance. Now, these vitamins play multiple role in multiple enzyme pathways. Still, they cannot be produced by the body. So that's why it's essential that we consume adequate quantities to keep everything working well. So vitamin B3 rich foods, fish, dates, mushroom, broccoli. Okay. Here it's important to know that vegetables and cereals are poor sources. So you can get niacin deficiency quite easily. Okay. And the RDA is high. So the B1 and B2 we saw is 1 to 2 milligrams per day, whereas here it is 15 to 20 milligrams per day. So the deficiency features, pellagra, classica. So it's common in whom maize is the main food, so which is a poor source of tryptophan. So the 3 Ds of pellagra: diarrhea, dementia, dermatitis. I wanted to show this so that it in nutshell captures what is in pellagra. Sorry, it's not clearly visible. I'll show it in subsequent slides. Okay, so dermatitis. So it's in the hand, symmetrical erythema over all these unexposed areas, hands, legs. Okay, Castle's necklace is described, and pellagra's group. So some skin rashes with erythema. Okay, and this is again seen glossitis, stomatitis, diarrhea. So at least remember diarrhea, dementia, and dermatitis. So skin reactions, rashes, and over palms, soles. There is Castle's necklace. There is altered sensorium, and there is going to be diarrhea. If you have all these 3, then you suspect it is pellagra. Okay. Rapid clinical response and daily administration of 50 to 300 milligrams of niacin. So we generally give as multivitamin cocktail because many of them share a common phenotype. Going to B5, pantothenate. So it is a component of coenzyme A which is involved in energy metabolism. Not much studied initially. After a few reports only they have started talking about pantothenic acid. There is no real RDA which is available. Adequate intake is considered 5 milligrams a day. Deficiency is rare, but you get that. What is the deficiency called? Sorry? This burning food. Yeah. Okay, so that's what pantothenate deficiency is. So you get dermatitis, hair loss, depression, burning foot syndrome, and muscle cramps. Toxicity is very rare. Not much is known about pantothenate's role. Only thing is it is involved in coenzyme A, so part of involved in energy metabolism. We rarely get to see this in clinical practice, but definite clinical syndrome, the burning foot syndrome is well characterized because of pantothenate deficiency. Okay, pyridoxine, B6, is in B1, B2, B3, B6. Physiological functions, they support over 100 different enzyme reactions involved in amino acid group transfer, carboxyl group transfer. The enzymes support everything, literally everything. So you are involved in amino acid metabolism, carbohydrate metabolism, RBC synthesis, and then also neurotransmitters. Hence, deficiency will have manifestations at all these places. The pyridoxal 5-phosphate is coenzyme in so many reactions: transamination, decarboxylation, glycogen metabolism, fatty acids. And in CNS, it is a coenzyme for GABA transaminase. So what are the sources? So fortified cereals, meat, fish, vegetables, non-citrus fruits are good sources of B6. Okay, and the RDA recommended diet intake is 1 to 3 milligrams per day. So again, invariably 1 to 3 milligrams for most of them. We can safely write that. So what are the clinical manifestations of pyridoxine deficiency? So classically there is a dependency syndrome and then the deficiency symptoms. The dependency syndrome we commonly see B6 dependent convulsions, B6 responsive anemia, and homocystinuria. So many times we get neonates with intractable epilepsy, and then we suspect there could be pyridoxine deficiency. We add pyridoxine empirically and then see response. And if it is because the seizure is because of pyridoxine deficiency, very rapidly they respond. The seizure is literally abort. You might have to give 4 or 5 anti-epileptics. Seizure is not getting controlled. You just add pyridoxine and then see there is excellent response. By the next day, child neonate does not have seizures at all. So that is one form of neonatal seizure which is having excellent response to pyridoxine. The deficiency system symptoms, you get anemia and neural involvement. So this one we all know classically. So INH induced. So patients on ATT generally we end up giving pyridoxine because peripheral neuropathy by INH can be treated by giving pyridoxine. And it is not the only mechanism, but a predominant mechanism of INH induced peripheral neuropathy is by pyridoxine deficiency. So supplement pyridoxine. And it is also an important cause of microcytic hypochromic anemia, not very common in infants. Okay. So you will suspect B6 deficiency if you get young neonates or young infants with refractory seizure, not for the first episode of seizure. Most common is again febrile seizures or some structural abnormality. In them you will really not suspect pyridoxine deficiency. But if there is refractory seizure requiring multiple drugs, or you get some skin manifestations, you would definitely think of pyridoxine deficiency. And you will see that there is excellent response the moment you treat them, add pyridoxine supplements, the seizures get quickly aborted. Okay, so this is about pyridoxine deficiency. I think this is the last slide. B7 biotin. So functional critical in energy metabolism, so NTC cycle and gluconeogenesis, again acting as a cofactor. There is no real recommended dietary allowance. An adequate intake is 30 mics per day. Deficiency is really rare, but biotin is promoted so much for hair loss, and most of these treatments generally involve biotin. So you have as a multivitamin supplementation, majority of them in therapy for hair loss, they end up using biotin. Really don't know how much effective that is, but you can see it very commonly in all these products. Otherwise, myalgia, dry skin, depression and all are documented with biotin.